Coming up next on Headline Humboldt, we sit down with Eureka High School graduate Dr. Eric Nelson from the University of Florida's Emerging Pathogens Institute to talk about moto-meds, a program he's involved with to deliver emergency medications to stranded patients in Haiti. Also, thousands of poor kids and adults are getting kicked off Medi-Cal because of paperwork issues, even though they still qualify. Coming up now on Headline Humboldt. From the top of Humboldt Hill, this is Headline Humboldt. I'm James Falk. Thanks for joining us. Maybe it's just the speech they give to all high school kids, but back in the early 1990s, we were told that our graduating class, the class of 1994, was special. Looking back at my own experiences and those of many of my classmates, I have to say that such a prognosis has borne out. For example, a few weeks ago, I was approached about a story of a doctor who'd come out of Eureka High School and was now part of an amazing program providing much-needed medical assistance to folks in Haiti. The stories from Haiti have, over the past several years, been apocalyptic, from earthquakes and other natural disasters to political upheaval to violence and to rampant gang violence. Two violences there. Sorry about that. Such an effort to aid the resilient people of Haiti would be a story no matter what. But I was even more surprised to learn that Dr. Eric Nelson was actually a classmate of mine at Eureka High and had gone on to do amazing things with his life and career. He'll join us via Zoom after the break. But as a father of 4 kids, I want to underline the fact that from modest beginnings can come great things. Dr. Nelson is now a prominent physician with the Emerging Pathogens Institute of the University of Florida, and he's made great progress in using the tools at hand to provide innovative solutions to seemingly intractable problems. Such an example is important for us all to mark and reflect upon. How much good are we doing with the life and opportunities we've been given? We'll be right back.
We have such a treasure in KEET TV. I think everybody should be a member. Think about all of the news programs, all of the mystery programs and masterpiece programs that are available to us here. I love them all. It's hard for me to decide what is my favorite program because there are so many. So please, become a member today. And thank you.
Thanks for joining us, Eric. Can you hear me?
You're just fine.
All right, that's good. That's good. So thanks for joining us. I don't know if you managed to hear my spiel, but I thought, 1994, ready to soar, as you pointed out when we first spoke. And it sounds like you're soaring. The program moto-meds, let's start there. Can you describe for us what exactly it is and what it accomplishes in Haiti?
Yes. So moto-meds gets at a very core item that unifies many parents and anyone that has a loved one in their life, which is in that moment of isolation, if a loved one falls sick, how do you access basic things like knowledge and, in this case, medication in hand? And this is a problem that we face here in Gainesville, Florida. I know it's a problem that parents might face in rural Humboldt County. And what we did is we looked at this kind of commonality of a problem and tried to find where in the world might this be most difficult to achieve. And so we work in Haiti, and we work at nighttime, and we work with families across the mountains and the coastal regions of Haiti. And what moto-meds is a telemedicine and medication delivery service, such that families at 6 p.m. Till 5 in the morning, if their kids get sick, they can call into the service, and it's nurse run and nurse practitioner run. And the nurses go through a triage, assessment, and plan. And if you have an emergency, we help direct that family to a hospital down the mountain. But there's not 911, there's not ambulances, there's not electricity, there's not formal address systems or formal roads. And so what you really want to do is get the families in the pre-emergency state to give low-cost, effective medications to avert emergency. So after they go through a triage, if they don't have emergency that flags immediately, we go through the assessment and plan, and then if they live within the delivery zone, we coordinate basically an Uberized pool of motorcycle drivers to transport medications to what we call green cases, which are mild cases, or if there are moderate cases, we transport medications and a nurse to that household to do an in-person exam. And then we help basically be a bridge through the nighttime to get them safely onwards in their care.
Yeah. So what are the challenges? I mean, you mentioned it a little bit just now, but if you could go into a little bit more detail about what the challenges are on the ground in Haiti, and I guess you're also looking to do it in Ghana, is that right?
Yeah, so we're doing a test of transportability to Ghana, and all of this work is really under the domain of a research initiative because there's not a WHO guideline for how to do this. There is not a logistical roadmap on how to pull this off. And so the National Institutes of Health of the US government has been funding this for about 4 years. And it's a very complex initiative. And the story really begins back in 2010 when I was a first responder to a cholera outbreak in Port-au-Prince. And we did an outstanding job providing care from 10 a.m. to about 3 in the afternoon or 4 in the afternoon, because those were the only hours that we could safely operate. But in the remaining 18 hours of the day, when the clinic was closed because of violence and we couldn't access that part of the city, we had high rates of mortality. And then in the morning, there was a queue of patients in shock outside of our clinic. And at that moment, I said, if we can't get to families off hours when the clinics are closed, my mission is null. Yeah. And so at that point, I began pivoting my career to thinking about how do we provide early access to care in really difficult places. And then since that time, the UN peacekeeping force left the country, the government collapsed, the currency collapsed, access to fuel became very difficult, gangs took over the country, and have roadblocks throughout the country, and it became a conflict zone. And there are many conflict zones across this planet, and developing a logistics mechanism to get early access to care in a conflict zone, it sounds like an important idea that people would want to support, but actually operationalizing it and getting it approved would be almost impossible. Yeah. So because the country kind of fell apart during the deployment of moto-meds, we became a really singular opportunity to figure out how to pull off these logistics. And I'm really proud because we are approaching our 4th year anniversary, and it's been funded through the National Institutes of Health, also private donors. And it's just been an amazing grassroots initiative. And then today, there is a tropical storm going across the Hispaniola, which includes the DR and Haiti. And what will happen is that as those floods hit the community, our case counts will double because diseases will spike, and we'll be there to respond.
Yeah. That sounds like an amazing story and sort of inspired thinking on the part of you and your partners. How do you guys go about recruiting the drivers? Is there any special training that needs to go into that, or are they medical professionals? Where does the pool of people come from?
So the pool of people comes from the pool of motorcycle taxis that every morning drive their motorcycles up to the top of mountains. Mm-hmm. They pick up children, they put them on the back of their motorcycles, and they find their way back down the mountain to school by 7:30 in the morning. And wow. We had this idea that if parents trust the drivers to show up on time and then safely drive their kids down off the mountain, there is a lot of trust and goodwill and professionalism there. But there's also a granular sense of the road networks that is not on Google Maps. Yeah, right. And so we engaged those pools of drivers, worked with them to professionalize them and teach them some basics around medicine, and then paired them with nurses that could, take on the medical side of things. Yeah. So it's kind of bringing Uber to Haiti. Yeah. And leveraging that scalable talent pool.
Yeah. Now, I saw in one of the printouts that you sent over that over 2,000 kids you guys have successfully treated so far?
Yeah. So we've conducted now 3 clinical studies, and we're into the thousands, between 2 and 3,000 people.
And now, I mean, just to be clear, if you guys weren't there to provide this service, it's likely that these kids may not have gotten medical attention at all, or would have been delayed, which could lead to, mortality or other, bad outcomes. Is that right?
Absolutely. And a parallel story is in our study about a year and a half ago, 2 years ago. We were working outside of the southern peninsula of the country, and we launched a scaled study of what we're doing. And then shortly after we launched, there was an earthquake in the southern peninsula. And what happens typically with a large earthquake is you have first responders that go in, they stabilize the situation, and then in about a month, they pull out.
Yeah.
And what happens is that the clinics are not rebuilt by that point in time. So there's always a gap of 1 month to maybe 6 months after a major natural disaster. And we were positioned to pivot and then respond in that situation. And we didn't have funding, but we had the tools, and we went ahead and launched. And it just so happened that a funder came to the surface and funded that enrollment, and we still operate. And because that's the third largest city, being Okai in Haiti, we're now covering about 250,000 people, and it's quite busy and effective.
So it's in the one city in Haiti, is that right?
So we work in a couple of regions.
Okay.
One is just south of the capital, that's more rural and mountainous. And then the city of Okai is down on the southern peninsula, and it's got urban and then rural areas as well.
Now, it's interesting to me. It seems like that this is something that, and I think that that's what your approach is that you can deploy it in a lot of different places, and it's a model that can work in a bunch of different environments. What are some of this, lessons learned in terms of over the past 4 years that are going to be important in moving ahead and deploying it elsewhere?
Scalability is really tricky, and sustainability is really tricky.
Yeah.
And the reason for that is that if you are trying to help the poorest, most marginalized people on the planet, it inherently can't financially sustain itself. And so if you want to create a business model that does sustain, you're going to have to profiteer off of poor people, which is not ethical and is not actually counter to the whole mission. Yeah. So we have kind of 3 different camps of duties. One is to create a model of financial sustainability, and that should be an element of government support, private donor support, grant support, and some form of buy-in from the community and the families that we support. It doesn't have to be financial, but some sort of buy-in. The second thing is that we have to work with the World Health Organization to convey the pediatric guidelines we've built to the WHO and have them critically analyzed to make a standard of care that not just we can adhere to, but other parties that want to replicate what we've done. And then the third part is testing portability. So Haiti is very burdened with diseases and has some generalizability because of that. But our pivot to Ghana has tested us in different ways. We're working in Accra, which is has one of the largest slum communities in the world. It has a very high rate of malaria, which Haiti does not. And so it's forcing us to adapt and convert our guidelines to fit that need. The next thing is probably to make a pivot to South Africa and then onwards to Nepal to have some sentinel sites around the world that we've shown proofs of concept, and then put together the moto-meds package in a way that can be put on a shelf. And if a country in need reaches out to us, we can take it off the shelf, localize it, and deploy it. And this concept and this model is not unique to developing worlds. I think about if a family was up late at night with a kid with vomiting and diarrhea at 2 a.m. outside of McKinleyville, or somewhere around the Hoopa area, or outside of Garberville. how do they access knowledge and basic medications to avert emergency? So the model, I think, has potential in the US as well.
Yeah, absolutely. I mean, we have some vast underserved areas in Humboldt County and throughout Northern California and in a lot of the rural areas where people, if they don't have a vehicle or for whatever other reason, can't readily transport themselves. Real quick, can you talk a little bit about the difference that quick care can make in terms of a patient's outcome? I mean, how important is it that you get a patient to the doctor right away in some of these instances?
It is super important. So one reason why people do not go into pediatrics is because children will look fine. They will be smiling, they'll be playing with their toes, and then they might have an illness and they still look okay, and then suddenly they decompensate. And that's because physiologically children can squeeze all their blood vessels. They have so much more lung capacity than adults do. They can sustain themselves even as they're getting sick. And so the trick is identifying kids early and getting basic things like albuterol for asthmatics or amoxicillin for some sort of ear infection or Cephalux for like a skin infection. There's just less time for children. Adults, there's often more time and the pace can be more measured. Yeah. So if it's a decompensating child here in Gainesville or in Haiti, the physiology is the same and there is a real-time pressure. So one of the things that we have is something called the silver 2 hours, which is we try to make sure that we get the triage in and the delivery out in under 2 hours. And we do so actually at a better rate than that. We average about 72 to 80 minutes per delivery.
And what kind of meds are you guys delivering? Is it across the gamut, or is it just a few select things involving communicable illnesses?
So we try to keep things simple. And I saw you showed up a slide there from a design concept and group called IDEO.org, which is out of San Francisco. Mm-hmm. And that whole concept is around hearing, listening, prototyping, iterating. And in our case, the hearing phase started with what are the dominant diseases in this space? And we took all the field of pediatrics and boiled it down to 6 chief complaints. And number 7 is other. And what we do is that our guidelines manage those 6 chief complaints, which is about 92 to 95% of our diseases. Wow. The other 5% of cases roll over to on-call doctors. Yeah. And so it's very simple things like you see there in Humboldt. It's fever of unknown source. It's ear infections. It's trouble breathing. It's vomiting, diarrhea. It's skin infections. It's just more extreme than what you have in Humboldt.
Yeah, absolutely. Now, one of the things that we talked about when we first communicated about this story was there is a trope out there in pop culture and elsewhere, which is unfortunate, about the idea of the white savior or the Western world coming to rescue its more benighted associates in the third world. And you were very clear that that's not the narrative that you want to be told here, because it's not just you who's doing this. But could you explain for us a little bit about what your concern is there and how you guys address that?
Sure. So there is a movement and a really important movement called decolonizing global health. And what that means is that there are mechanisms that have been around for more than a century, in which often it's a funding agency or a donor that comes from a rich country and then wants to do good in a poor country. And because the money is flowing from that developed country, often through a US-based investigator or some sort of a philanthropist onwards to that poor country, there is a financial umbilicus that just naturally has kind of come to be over those years. But with that, just like anything in life, there's an aspect of control and power that comes through that umbilicus. And how I see things through my eyes and through academia, through my eyes as a pediatrician here in the state of Florida, I see things differently. And so it's really important that we approach this work from an equitable standpoint, and actually more ideally is having the foreign partners lead and people like myself being the consult and the helper. And so there's a really important piece of empowerment of identifying leaders within foreign partner countries. If they need career development, we provide that capacity building, and then those people are the leaders and in charge of the operations. And that's how we've worked to build things in Haiti as well as in Ghana. And what that looks like is that our call center is 100% Haitian. It's nurse and nurse practitioner. We have helped train our lead nurse who grew up in our study area. She went to nursing school and nurse practitioner school, was licensed in that area, and she runs moto-meds. The on-call doctors are based in Port-au-Prince. They are also Haitian trained and some of the best physicians in the country. And so that is an example of focusing on equitability and empowerment that makes sure that this is not falling into the colonization model of the past.
Yeah, I think that's important. I mean, especially consider some of the political pressures that have been surrounding the WHO in recent years, and vaccines and all that sort of stuff. And it sounds like you guys have done your homework and are taking a sound course in that regard. Have you been to Haiti recently?
That's a complex question.
Sure.
It is. I've worked in many conflict zones and many unstable situations. And Haiti right now is incredibly hard logistically. And we don't want to make our visits to the country become a liability. Yeah. And we don't want to put at risk our primary mission simply by me doing a field visit. So right now, to safely get to our field site is really difficult, and it's probably not worth the risk and liability.
Yeah.
So that forces us to rely on Zoom. It forces us to ship a lot of our supplies. We have a small armada of motorcycle drivers that will find their way safely into Port-au-Prince, and it's important to know that like most roads have roadblocks and you have to pay your way through it, and most of those roadblocks are armed. Strangely, one of the things that about moto-meds, because we work at night, the people with guns go home when the sun goes down to their families. So at night, those roadblocks are not armed, and we literally like drive over them to do our nighttime pediatric care, where during the daytime, a lot of the daytime clinics actually have to shut down because it's too violent. So I was last there about a year and a half ago, and I'm hoping to go soon if it's safe.
Yeah, well, certainly stay safe. We have 2 minutes left. One of the things I wanted to be sure to put up on the screen is the URL for donating to your program. You guys do accept private donations, correct?
That is correct, and it's played a really important piece to bridge when grants aren't available. One of the parts of sustainability, which I didn't get to, is digitizing our clinical guidelines. And a lot of what I do is software development. So we have digitized the guidelines, and we're about to deploy that into Haiti. And we feel like if we can pull that piece off with our kind of hub and spoke model of delivery zones, we feel like we can actually have a pathway to scale across the country, which is about 10 million people.
The URL for the donation page was up on the screen there, if you caught that. And real quick, a lot of us don't have experience with a place like Haiti. Haiti has a beautiful history. It's and the people there culturally are, complex and vibrant. Is there anything about the Haitians or this project that you think that people should know that maybe they can't see from the surface looking out?
Haiti is unlike any other country I've been to. There's a passion, a sense of caring, a sense of finding joy when there doesn't seem to be any venue to do so. And I find that inspiring. And then our former chair of our department of pediatrics here at the University of Florida used to say, a society is judged by how well they take care of their most vulnerable citizens. And I view citizenship as global, and that's also where I find a lot of dedication to my work.
Well, Eric, Dr. Nelson, I appreciate you taking the time and sharing with us your work, and I think you're going to be commended for the excellent opportunities you're trying to help bring to Haiti. Thanks for joining us.
All right. Likewise for your work with PBS.
KEET TV, baby. And go Loggers, right?
Go Loggers. Take care.
All right. We'll be right back after the short break.
Friends and supporters of KEET TV, we are calling all who have a passion for public television on the North Coast. KEET is looking for a diverse group of people to join its Community Advisory Board, or CAB. CAB members play an advising role to management and act as KEET's ambassadors within the community. Meetings are held quarterly on Zoom. Go to KEET.org, find the link for CAB, and get involved today. We look forward to meeting you.
Over the coming year, about 2.3 million Californians, 1 million of them children, are expected to lose Medi-Cal, which is health insurance coverage for low-income families, as the state reassesses eligibility after the pandemic. In June alone, 225,000 people were disenrolled from the program, including 64,000 kids. An estimated 89% of those people still qualify financially. Joan Alker with the Center for Children and Families at Georgetown University has said that many families either moved or haven't received the renewal letters, or they're having trouble with the paperwork. The process is confusing, she said, and the burden is falling on the families to push through the rigmarole. Confusion is rampant because the system does not issue receipts that prove that documents have been received or notify people that their packets are being processed. Help is available on the State Department of Health Care Services website, keepmedicalcoverage.org, and on the Children's Partnership website, allinforhealth.org. That's all for this week in our medical episode. Stay tuned, stay informed.